Hey, Nick, are you okay? We usually record when we do these presentations so we can send it to you. A
Sure.
lot of people don't some don't like that, but at the same time it helps us kind of remember what we said as we talk. So
Fine with me. I have a very salty mouth, so no, I'm teasing.
oh dude, hey, join the club, man. That's funny.
It's terrible. It depends on the day and which child is annoying me.
So Nick,
I
I know you
literally
do a
had my
lot.
daughter just walk by and I was telling Thurman, I was like, man, her sarcasm is 11 out of 10. So I get you.
Yeah. So Nick, I noticed that on your profile you do a lot of diagnostic work.
Got get it from somewhere.
You out in New Jersey?
I think you froze up a little bit. Let me see if it's Wi-Fi. All right, you're back. You're
All
back.
right. Now I
Can
was
you hear
asking.
me?
Yeah, I can hear you. I can hear you well. Now I was making
Perfect.
the observation that you do a lot of diagnostic work out in Jersey.
Yes, yes, we do. We do. So we run the largest clinical lab in Jersey, which is the largest business unit. But we do, some other healthcare ventures as well. We're in the health data space. We're in the surgical center space. We're in the medical real estate space, staffing space, and then completely on the other side of the house, we do construction. So own and manage commercial real estate. Some of that's hotel and hospitality. Some of it is mixed medical. Some of it's warehouse. Some of it's development. And we're headquartered in South Plainfield, New Jersey.
You're doing a lot.
The team does a lot. I just try to support the best I can when I can.
When you say medical diagnostics, so do you do full blood toxicology, infectious disease? I mean, is that everything for that clinic that you guys have?
Correct.
Oh man. Okay.
So about 380 assays under the roof. It's a very large test menu. 97% of all the tests that are done are done in house. However, on October 31st, it's a couple $100 million business unit.
Yeah.
But we just sold that business to LabCorp.
You just sold the lab business to LabCorp?
Correct.
Okay. Okay. Do you right now when you do your toxicology, do you have anything right now that can detect fake urine or adulterated urine besides the normal like creatinine and tests like that?
So in your methods, you can basically look for adulterants, and pH, and creatinine, like you said. Now, I've done this a long time, and I'm sure there's something out there, but I don't know what that is. I'd have to ask someone smarter than me what goes into
Good.
that.
Hey, and there's no trick questions as we're talking either. We've just found a company out of Florida that we do a lot of work with, and they're open to working with anybody. But they have a specific product that can detect fake urine and adulterated urine that can be run on an assay. So it's just
that's interesting. Yeah. So to your point, there's always a better mousetrap out there.
Yeah.
The challenge is always reimbursement.
Sure.
On what we do, right? So, there's a lot of people with great mousetraps, and then there's people with lousy mousetraps, but they have the payer contract. So
they have exactly, and the worst ones usually have the contracts. Yeah.
Yeah.
We honestly, we're coming at this from a completely different angle. And
Yeah, tell me what you guys do, and so whoever's in charge of your marketing, right? Kudos to them. You guys certainly pique interest, at least from me. And I don't know what the hell you do, so that's pretty good.
Thurman, way to go, man.
Yeah.
Yeah. We sell timeshares is what we do. Yeah.
Yeah. Disney timeshares.
Yeah. No, I mean,
it's not Maine Disney either. It's it's Kissimmee.
Yeah, it's Disney out of Louisiana is what we specialize in. But
Disney Cruise Line timeshare.
Cruise lines, yeah. No, I mean, to be complete, your background is going to make this a hell of a lot easier. Usually we have to explain this to people, but Thurman, where do you want to go? You want to just get going? We're waiting for one more person. Or are we just good to go?
Let's just go on because he's aware of what's
okay.
So let's just go.
Cool. So
perfect. Thanks, guys.
So to keep it really simple, Thurman's a therapist. I'm a nurse. Been a nurse for 15 years. Thurman's been a therapist for what, 25 years?
Yep.
Okay. And our approach to this was toxicology sucks, but it's a necessary evil. And one of the things that sucks about toxicology is everything's based on a pass-fail measure. And if you do an assay, well, everyone argues that it's wrong. So you do a confirmation. And then just like the payers say, it's expensive. Everyone looks at that one line item and then files it away and says, you either pass or you fail. And what I started noticing is, so I've been a nurse for 15 years, but 8 years specifically in the lab industry, where I've been doing consulting and helping clients understand what to do with the lab results and honestly going to court a lot. But it kind of explained to providers what the results mean instead of just pass fail. And we started talking to a lot of legislators in a bunch of different states. Utah, so I'm from Utah, Thurman's from New York. And the legislators that we talk to are screaming with how much money they're spending with no outcomes. Everything. I mean, you own a clinic, right? So if somebody doesn't walk after surgery, you know something's wrong. But everyone knows in the substance abuse world or in the mental health world, there are no outcomes to all the money we're hemorrhaging and spending on. So my thought was, about a year ago, I had this idea of starting to aggregate lab data to make it useful. When Thurman saw it, as we were playing around with some different things, he started looking at it and he says, you know what programs could do if they could start seeing what their clinical outcomes were? They'd start changing their programs based on what their data said instead of what the clients were telling them subjectively. What happened then is we started aggregating lab data. We filed a patent for aggregation of lab data. So we're not a lab, okay, by any means, we're not a lab. But what we want to show you that Roots does is we can now start aggregating not only lab data, but we can start doing anything that's tied to a human body in this database to start overlaying patterns and overlaying literally predictive analytics when it comes to healthcare.
Okay.
We started seeing things that completely blew us away. And now that we're starting to talk with states, like we're starting to talk with the state lab in South Carolina, Wyoming, Utah, Alaska, about putting all of their forensic data into this, to where now they can start looking and just saying, hey, here's our infection rate, but where is it coming from? And how does that overlay with STDs? And how many of those people aren't taking their antipsychotics? And it's a way of looking at things completely different from a regulatory or even a payor type system. And that's what Roots is. Okay.
So my antipsychotic is not in the screen. It's not showing up. And I also have X behavior or X outcome. So here's my clinical pathway and my intervention.
You can now, see, one of the hard things for me is like I go over reports with clinicians all day long, okay? And they're like, are you sure that's heroin? I'm like, yeah, it's heroin, but are you noticing they haven't taken their risperidone in their last 5 tests? Oh, that explains their behavior. I'm like, no shit, it explains their behavior. Maybe they should take their antipsychotic and then they won't do drugs or meth, or they won't. I mean, people aren't even participating in group or activities because they're so lit on Seroquel, right? There's reasons people are acting the way they're acting, and we're saying use the lab results to treat rather than just pass fail. But
Well,
when you,
I mean, so many of these clinics are the good clinics get it, and then you have everybody else. So I like the approach to go after it from a legislative perspective, because if you don't regulate it in, they just don't care.
they don't care. No, absolutely. And you know, too, coming from a clinician or from a lab, you're competing with everybody else. But at the same time, when you turn around and say, no, our product's better because of X, and I have this standing joke I always say, where if you and I were riding horses and I said, hey, something's wrong, you should get off that horse, you're going to argue with me because it's subjective. I'm seeing something that you should get off. You're going to argue with me. I'm fine. Let's keep going. But if I look at you and say, man, you're sweating and you're breathing really heavy, and your pulse is racing, your eyes are done, you got to get off that horse. You're going to get off because I can measure everything I just told you. That's what lab values are. And if you can start overlaying things and say, why is it that this one rehab and this is coming from the payer source, right? Not just the clinic. I'm so tired of talking to clinics and clinicians, but the payers are looking at these clinics saying, wait a second, why is this one clinic in New Jersey prescribing all these medications, but the database now says they have a 5% compliance rate? Nobody's taking the medications they're prescribing and fulfilling at the pharmacy. It's not in anybody's system. What's going on there? Or programs are just consistently asking for more and more and more and more money. But when you look at the data, nobody's taking the medications they're prescribing. So how therapeutic is the treatment if they're not even taking the meds, or they're charting all these things? Like Thurman's a genius on teaching people how to chart. But if they're charting something that's completely contrary to what the lab data says, how good is that program?
Well, I mean, follow the money. Odds are that program, whether it's in Jersey or some other state, is a 501c3, and they're participating in a 340B program, and they're just running scripts out to make money to be able to, to cover whoever owns the program.
And right? There's all kinds of reasons, but it's a black hole right now. When we started showing these to some different groups.
I mean, line up the 340B money with the pharmacy spend, right? And then do they have a 501c3 designation? And then if you put that data in front of a legislator and say, all right, go sick the dogs after them, right?
Well,
so you're paying them to write a prescription to get filled to make money. That's never used.
No, exactly. And when we even go through antipsychotics, like before Abilify went off label, now it's aripiprazole, right? But when you looked at Abilify and you just looked at what we saw in the data, there was a 7% compliance rate. Before aripiprazole went off patent, it was $28 a pill, but no one was taking it. It was being fulfilled all day long. So what we found then is when we start showing this to states, as long as it's a data source and it's tied to a person and it's a lab value, we can show you anything that's on the demographic sheet. Not demographic sheet, anything that's on the requisition form. So the date that it was collected, the date it was processed, the zip code the person lives in, zip code of who ordered the test, what they're ordering, what was positive, what was negative, what was expected, unexpected. Then you start overlaying it with population controls. This is what we found in Utah over a lab that we're working with in Utah. And just so you know, too, in full transparency, like I said, we're not a lab. We're working with a lab right now in Utah. We've signed paperwork with a lab in Texas, in Florida. And what we're doing is we're aggregating their data in to where you could start to look and say, what's going on in Georgia? Well, what data do we have in Georgia? What lab do we have in New York that has, I think the end of January, we're working with a program in upstate New York where they're a hospital with their own lab. We're going to be ingesting all of the data from all of their labs to start showing patterns in upstate New York. Same thing, right? Literally your current program. The data set that I want to show you right here consists of 91,000 toxicology samples. A lot of them are rehab programs. This is for a 3-month period, okay? where you could,
Yep.
no, I'm sorry, not a 3 month, 6 month period. Some of these are the same person tested over and over again, but it's a total
Yep.
of 91,000 samples, right? First time we did this, all we're thinking about is toxicology, but it really changed when we started looking at the data that we just saw in Utah, and every state's different, right? Every geographical area, income, I mean, you start talking about really epidemiology, what's going on in those areas. This is one of the things that we found was interesting in Utah, is that obviously opioids were the #1 abused class. The antidepressants and muscle relaxants were number 2 and 3. And you can see that females overwhelmingly abuse drugs more than men.
I've been saying it for years. Well,
right? I mean,
our
those
country
are
country has changed a lot in the past 5 years, but 6 years ago, you could be a brother walking down the street. They're going to turn your pockets out looking for an ounce of weed and throw you in jail. But Mary can have $600 worth of some illicit opioid prescription that she got from her best friend, which is
and just walk
crippling to somebody. And the guy who's got a joint in his pocket's going to jail.
Yeah.
Right? The moms in our country are the derelicts. It's not anybody else.
We originally started looking at this as having logins where you could see two things, either the HIPAA level on the clinical side, you could see the most recent lab on a person, or the macro level, which is like this. You could see things, start to see the patterns going on. Ever since we started talking with state labs, we have now created a new login for law enforcement, where they can actually start tracking, why is it that opioids are higher in these areas because of single women or whatever else, right? What do you want to see? That's the whole purpose of Roots, is here's all the data. What do you want to see with it? Because this was the one that shocks everybody. Okay. This is right here by gender, the most abuse of drugs, gender and age. And check this out. Look at what happens when you look at females. They, just what you said, right? Female women in the between the age of 42 and 46 abuse more drugs than any other class, any other group.
Yep. They're a train wreck.
They are
an absolute train wreck.
But you see all the billboards talking about these people, locking up your medicine cabinet and all that other stuff. And so even when we show this,
if you look, it's middle-aged white women in middle to upper class suburbia that are just churning through opioids like nobody's business.
And
they go to 5 different doctors. They all go to 5 different doctors.
Well, and they also share. That's the other thing we're starting to see, because
they share like crazy.
Yep, they share.
Venmo.
And those,
see if you can get Venmo in this thing, right? I mean,
well,
track the opioid abuse by the number of $50, $100 Venmo payments by Mary and Susie.
Yeah, there's a lot. This thing right here, the validity and consistency, we put this up because there are a lot of labs that share a lot of information, but when you look at what percentage of it is fake urine or adulterated urine, they can't tell. And we've actually shown this to Department of Transportation and SAMHSA about how you can show the difference. And they were blown away by it because they know they're getting crushed by fake urine. And so
what's amazing is, wow, you could probably just use like an infrared spectroscopy, right?
Yeah,
I would imagine something in IR could
absolutely with a heat map
determine that pretty quickly.
Yep.
So, our country is designed not to know things, right? So the billing code for creatinine was disallowed because it quote unquote cost too much money, right? So it was disallowed. So anybody who billed that, now, the government came out and said, hey, at a state and federal level, hey, this is an outlier. Here's your heads up. And then 2 years later, they came in and did an audit on everybody. So you're not only disincentivizing the screening of fake urine, you're punishing the behavior of identifying if it's fake urine. So it's not only are you not allowed to run a creatinine and not bill for it? But if you run it and you give that information to the physician, it's a kickback. So I can't run it and tell you, the pH is off and the creatinine's non-existent. I'm not allowed to run that and give you that information. I'm then providing a kickback. I'm providing something of value.
Well, can I go up you on that? In the state of Utah,
Sure.
we actually worked with the state of Utah with this lab here in Utah, and we said, hey, change your format on your LCMS where you just do positive and negative. You don't give quantitative amounts, you just give positive or negative. So they went to the state and they said, hey, look, your analyzer code is X, your full confirmation code is Y, but we can give you the same amount of data, same amount of information at that cost. And they said, nope, by definition, because you use this machine, you're doing this. And I went back to them and I said, but by your own definition, this is identifying specific drugs, which makes this a confirmation. So your own definition that I now have in an email negates every screen that is done in the state of Utah as a confirmation. And like, we don't see it that way. I go, your own definition says that, which means you could have a class action lawsuit if anybody was put in jail over a screen, because by definition, it's an LCMS, which should be thrown out as evidence. And they're like, well, we don't see it that way. I'm like, man, you guys are going to get screwed if a lawsuit comes out. But again, it's incentivizing, and everyone knows how
they
dirty
don't,
the lab world
they
is.
don't care.
They don't.
They don't. They don't.
The lab world is
Hey,
super dirty.
Some questions I have for you. So you said you get data from the payer, right, or from the state. Can you talk to me a little bit about where those data sources come through, what the actual technology is, and then how and where you store it?
Yeah, so what we do right now is we work with labs. So we're talking to multiple different legislators in these different states saying, look, if the state's paying for all this, the state has no access to anything. They've got to run their own reports. They've got to do their own quantifying of everything. We basically said, look, if Medicaid's paying for it, have those labs dump it into Roots, and now the state has access to all the information they're doing anyways. So we don't want to go with the hammer and say, oh, you now have to work with us because Medicaid's paying for it. So we're working with labs that want to start working with it and kind of present Roots to their state. Say, hey, here's what our lab's doing. Here's why we're different, type of a thing. Because we get our information from the labs themselves. Like I said, we aren't a lab. We're not competing with anybody. But what we do is the agreements that we do with.
So what I've seen that has worked in the same design and scope. So in New Jersey and in New York, probably Pennsylvania. Pennsylvania is a very wonky toxicology state. But when the state came out and said you have to share with us this data, and the email comes from the state, almost every lab complies with that request.
Correct.
You
don't
got to go into the right person. Yeah,
exactly. And so that's what we're looking at, because part of it is labs want to differentiate, right? They want to show something different. Everyone's selling the exact same thing. Whereas if you can turn around and show compliance to a program, right now I'm manually creating reports for different labs to show compliance. That way programs can show they're getting better, to pay the payor, all those other things. This automates me. So any lab that signs up with us to do this and to share their data with us gets full access to Roots. They can now use this as a data source or as an analytics page for their lab to show their clients or to go get more business. We actually have a lab in Florida is applying for an RFP right now based on the data they're showing from Roots with their lab. So that's kind of the handshake.
Yeah, so most of the data, the handshake, the data comes from commercial labs, you would say?
Yep, commercial. And then we barely started talking to, literally the beginning of this month, the state of Wyoming. Somebody somehow, I don't know how it happened, but somebody from the state of Wyoming said, I want a demo on Roots. So we showed it to them. And they said, can we put in our forensic data? Can we put in our rape? So we start getting those heat maps of where rapes are happening. Does that overlay with medications or infections or STDs? And we're like, well, yeah. I mean, we even prison systems, we're designing right now, instead of showing a map, right? Instead of showing a map, it will literally show a prison where you can say, hey, Thurman got admitted today. Here was his drug test. Why is it that Mike and Rick and Bob all tested positive for the same thing Thurman tested positive for in this wing? And why are that? You know what I mean? We start overlaying. You could do 1 or 2 tests and get rid of everything in prisons based on data identifying where it's coming from. And so we're currently designing that right now for Juneau, Alaska. But it can be used in so many different. There's so much information in lab values that literally they just get checked and filed away, you know,
checked and filed.
That's it. That's all it is.
So when you take the data from the lab, you have how many labs connected right now?
We have 1 lab in Utah. We're integrating right now with Florida and Texas. Okay. In commercial labs. We're also we're in conversations right now with labs in Tennessee, Missouri, Chicago, and South Carolina as well. And honestly, upper New York, but that's a physician-owned hospital, clinic type thing.
So we have a lab in Utah. We have data coming in from them. What lab information system are they using?
They have a spitball system. It's so bad. I mean, we have another. Yeah. Oh my gosh. And so right here, you can see that we have, 91,000. We have been trying to unpack 300,000 more samples, but literally it's held together with duct tape and snot. And we're the ones that do the HL7 integration, or if it needs to be a dump or whatever, that's our side. We handle that. We unpack it and then normalize it.
So you connect in through a VPN or you create a VPN
whatever
tunnel.
You want to do. Mm-hmm. It can be a daily upload. It could be a weekly really whatever the labs want to do. But it's a lot more accurate when you can say, hey, this is a weekly refresh or whatever, because politicians are free. We have politicians right now that are screaming at us why we don't have new Utah data. And it's been 3 weeks of us unpacking what the hell they sent us. So, and then the other one is
your interfaces, you do those interfaces in-house. Correct. Who writes the interfaces for you? And then where do you store the data?
So we do our own interfacing with our own programmers. And then right now we're using Azure as our database.
All right. And then what's your interface engine?
I don't know that answer. I could have Oscar answer that question. I don't know.
All right.
I can make something up, but I choose.
No. All right. So then the value proposition is I have reports that are interactive, that give clinical insight for actionable interventions based off of the data that is quantifiable versus yes or no.
Yep.
And then I'm going to be able to go into my customers and upsell, and your vehicle to get you in front of the labs is you're positioning yourself at the state level so that they give you a warm intro into the lab, and then that allows you to start the conversation. So did I loosely grasp the value proposition?
Absolutely. No, absolutely. So if a lab comes on with us, they get us as part of them. We'll show you guys, you show your salespeople how to use this, how to work with it. Because one really quick case study was one of the legislators we were talking to as part of the judicial arm for the state. And he was talking about how, have you ever been to Salt Lake City before?
Not yet.
Not yet. So Salt Lake City is not New Jersey, not New York, right? But on the west side of Salt Lake County is usually where all the crime and the drugs are. Everyone says don't go to the west side. You know, that's the bad part of town or whatever. And
Yep.
he was talking about how the state is planning on building a $6 million drug rehab in Magna, part of the west side of West Valley or west side of Salt Lake. So we were talking to him, and I'm just like, that's weird. It doesn't sound right. So we just simply looked up, and I won't touch this because Oscar will kill me if I screw up his algorithms and stuff. But all I did was I looked up the zip code of Magna, and I just let's see what's out there. Okay. And this lab, they're called Beech Tree. They had 15 samples from people living in Magna. So I don't know where they went, right? I mean, I could look it up, but I just said, hey, if you live in this zip code, let's see what's going on. So we looked them up. 100% compliance. Okay. Every single person that was tested, not only were there medications present that were prescribed, but there was nothing else. There were no illicit drugs in those. Now I know it's a small sample, but I looked at them. I said, guys, you got a crime problem out there. You don't have a drug problem. And he paused and just looked at it. And he said, no one can argue with that. And I go, no, but the more labs that work with us, the better sampling I get. Now, if you want to talk about STDs, if you want to talk about, let's overlay that with statistical information from the state. What other labs do you have? What about blood work? Why is it that RWCs are so high in this part of town versus this part? I don't know, but an epidemiologist dreams over this data. Well, why not be the lab to present it? Why not? We are the visualization and aggregation of lab data. But when he saw this, all he did was he goes, you just saved the state $6 million. And I'm like, yeah, but we get 30% of that, right? You know, it's like, damn, I'm out of contract.
Split it 50-50. Let's split it 50-50. So speaking of 6 million, right? So starting something is very difficult, and getting anything slick like you have is exceedingly difficult. But then maintaining it, and as you said, you got to be careful when you're touching it so you don't screw it up, right? And then all the ambiguous outer joints that start to occur from multiple labs coming into one system, creating master patient indexes, all very costly, complicated things. So, all right, you sign up a lab, you have a budget, you have revenue coming in. Where does the revenue stream come from? And then how do you pay your bills?
So in a nutshell, it has changed several times. The more people that see this, the bigger the entities with 3 letters tied to them want to talk to us. So the more data that we have DOJ already talking to us. So we've already talked to DOT and SAMHSA about this. NIH is
how about right now? I gotta write a check for my Azure license, and I gotta write a check to Amazon Web Services to store it on, and I gotta write a check to Oscar, so Oscar continues to do my programming. Where does that monthly revenue come from?
So right now it's us building a company. We're a tech startup, right? But I mean,
I don't know. That's why I'm asking.
Yeah, we play poker with our cards up. So we're a branded company. We have pilots that we're looking at getting funded on through state entities paying for a pilot in Wyoming, Florida, and Utah. Well, actually, and in Alaska. And so we're looking at selling either a SaaS for the states, basically saying every Medicaid person that you use, there's a fee per year. We're looking at contracts. We're looking at a lot of different options. We've designed this to where we don't bill the labs for an integration fee. We do it and we set it up so it doesn't cost the lab anything to work with us. But the states, the insurers, the payors, Blue Cross in Chicago is now aware of this, and basically a way for them to start aggregating and using all the things they're paying for. And we would just basically be able to sell them. But that's why we want the labs that do work with us to get the sunshine on it and say, hey, look at why this is a good lab. Why aren't they in network? Or use this lab over these other labs because here's the data for them. More of a transparent view of toxicology. And I say toxicology, but lab work in general. That's our end goal. Or sell it to a big company like LabCorp. We'll sell it to them too.
So my advice would be with any large company, obviously, and I'm not saying this is lab specific, right? It's everybody. They also record the conversation, and then they go back and they take one of their 5,000 programmers and say, "Oh, go make this for me," right?
Yep.
Or they'll sign an exclusivity with you and say, "All right, we have an exclusive relationship. You can only work with us," and then they give you zero business.
Yeah, exactly.
It's awesome of them.
Awesome.
But you have the privilege of working with them. So here's kind of my thought. You tell me if this makes sense. So, I have some resources at my disposal, from a billing, coding, interfacing, opportunities. We have several different IT investments that we already do. So I don't know if you're looking to raise capital, or you're looking for partners, or you're looking for labs only at this time. But I have interest to further that conversation and learn more.
Yeah, we'd love that.
All right.
We are and again, if we're going to go to that level, I mean, later this week we have meetings with United Nations for contracts, because I mean, you think about it, everyone's spending so much money on lab work and no one knows what the hell's going on, period. And so Thurman's introduced us to a lot of people from the United Nations that are basically saying we are spending hundreds of millions of dollars in lab work that we want to see. So we're looking at contracts with all kinds of different groups, not just the United States. No one cares about toxicology anywhere in the world but the United States. But they sure as hell care about blood work or pre-births in India and things like that. So we are literally at that cusp of, holy crap, if anyone says yes. You know what I mean? Because it was just like, wow, we can handle it. But yeah, we're open to everything and anything. So we bring on our
so that's kind of what we do well, would be what is the security of the system? How can we make sure that it can handle the data?
Yep.
And then as Thurman's going out, knocking on doors and dragging it home to eat it, make sure that our bellies have enough room in them to digest it.
Yep.
So that would be
Oscar,
that would
Oscar
be
Ingalls. He's the guy to answer all those questions: how and the why and the what's, and protecting us.
And then for us right now, it's a good time to look at a solution that I can ingest data into, that wants to work at the state level, right? So those two things are what's of interest to me. So, right now I'm building a multi-specialty practice in Pennsylvania, New Jersey, and New York. And a big piece of our value prop is on risk adjustment coding and ingesting that data. So we're going to be reviewing vendors, but the more we can do in-house and the more we can help like-minded folks, I know is of interest to me right now. So
are
maybe
you doing your own ACO?
No. So as you know, right, I'm sorry, these people drive like lunatics. So we've been asked, so we've had a designated health services entity for a long time as one of our companies. So there's things that we can always do that wouldn't run us into compliance trouble. and there are things that would get us in compliance trouble. So, when we sold the lab business unit, that removed the OIG.
Okay, that makes sense then.
On working with healthcare entities. So, we've had business units, and we have business units that do simple things, right? Like annual wellness visit, chronic care management, pharmacy benefit management, healthcare staffing. We've invested in data IT companies before, and they've all gone well. So just because I think the space, like you said, is very active, right? Everybody wants to suck you dry, right? So it's of interest. So right now, what we're being asked to do is put together an MSO is, or right, an AMO, or whatever you want to call it, right?
Okay.
But there's basically two main plays. One would be clean it up and get it ready for private equity to come in, or clean it up and get it ready for a hospital to come in to make an investment, but keep the practices that are independent. Our belief is there's a couple revenue drivers out there that are attractive right now. So one is the $3 billion given to state health departments and local health departments. So they're going to need to spend that money somewhere. And from the past 3 years of what I've done, it's horrific how I don't even know the proper words to say about how ill-prepared, inexperienced, and poorly managed our health departments are. So
they're literally being led by the nose by lobbyists.
Not even. I mean, they're just so.
No, I feel you. I've had so many.
Yeah, they're so terrible.
And you look at them like, how can you make that decision? And they're looking at you like, well, that's what's best. I'm like, that's not what's best. How are you? I mean, I'm a nurse. I'm like, how in the world is that the best thing you can think of? But no, I'm sorry.
I had the fourth EUA in the country for COVID, right? And I'm the only EUA in the country that has saliva COVID. And I got most of the federal government contracts, the prison contracts, so like all these contracts, right? And the departments of health were terrifyingly bad, just bad. So, there's $3 billion out there. They're going to need a way to spend it. Can I give them what you're offering? I could probably take from, New England down to Florida for Thurman, right? And, continue to, just tee up relationships for Thurman. Thurman goes, clubs it over the head, drags it home, and, it gets digested by the beast, right? But it also helps us with our vertical of what we're trying to do. So, let's see if some of the math works together, right? In synergies on how we do this. Like I said, I have, a several $100 million business unit that I just shut down. So I have some resources there that, maybe you don't have, that could augment each other as we're looking to build up what's next. And then the second thing that has changed is the federal government and state Medicaid, through both the Relief Act and the Affordable Care Act, the Coronavirus Relief Act, right, have put in a vehicle for the state to elect to opt into Medicaid, and for Medicare Advantage or straight Medicare to identify and code patients with multiple comorbidities, and those patients will directly affect, through congressional act, the amount of money that's taxated from you and I, let's call it what it is, into the pool that then gives more dollars to sicker patients, right? So if I can take your lab data and I start with, hold on one second. This is Brian. All right, so I got to go right in this meeting. So if I take, there's legacy codes that exist that you can piggyback on doing what you're doing, right? So mental and behavioral health, but also there's diabetes along with those mental and behavioral health categories that you can use to start with. And then you just tackle on kidney disease and
CHF, absolutely.
and then just go right into the state health departments. So that's where my thought is. I got to run. Can you put something on the calendar for next week? And maybe we can talk through what a business partnership would look like. And then if it makes sense high level, we can do a sit down and talk through some specifics.
Sounds great.
All right, cool. Thanks, Mike. Thanks, Thurman.
Thank you, Nick. Talk to you soon.
All right, it's a pleasure.
Yep.
Thanks, guys. Merry Christmas.
Thanks. Hey, take care.
Merry
All
Christmas.
right, bye.
Let me shut this down.
Hey, I'll call you real quick, Thurman.